Welcome guys. Let's discuss another new topic today. Anterior cruciate ligament, ACL, injury. Introduction. The ACL are relatively common knee injuries among athletes. 1. They occur most frequently in those who play sports involving pivoting, for example football, basketball, netball, soccer, European team handball, gymnastics, downhill skiing. They can range from mild, such as small tear/sprain, to severe, when the ligament is completely torn. Both contact and non-contact injuries can occur, although non-contact tears and ruptures are most common. It appears that females tend to have a higher incidence rate of ACL injury than males. Clinically relevant anatomy. The ACL is a band of dense connective tissue which courses from the femur to the tibia. It is considered as a key structure in the knee joint, as it resists anterior tibial translation and rotational loads. The ACL arises from the posteromedial corner of the medial aspect of the lateral femoral condyle in the intercondylar notch and inserted anterior to the intercondyloid eminence of the tibia. Blending with the anterior horn of the medial meniscus, the ACL courses anteriorly, medially, and distally across the joint as it passes from the femur to the tibia. Functions of ACL. Primary restraints to anterior tibial displacement. Counting for 85% of the resistance to anterior drawer test, when the knee is kept at 90° of flexion. Secondary restraints to tibial rotation and varus, valgus angulation at full knee extension. Proprioceptive function. Presence of mechanoreceptors in the ligaments. Mechanisms of injury. Direct contact, 30% of the cases. Indirect contact. Non-contact, 70% of the cases, by doing a wrong movement. Anterior cruciate ligament, ACL, injuries are common in young individuals who participate in sports activities associated with pivoting, decelerating and jumping. Women are 3 times more prone to have the ACL injured than men and is thought to be due to the following reasons. 1. Smaller size and different shape of the intercondylar notch. 2. Wider pelvis and greater Q angle. 3. Greater ligament laxity. 4. Neuromuscular factors. Grades of injury. An ACL injury is classified as Grade 1, 2, or 3 sprain. Grade 1 sprain. The fibers of the ligament are stretched, but there is no tear. There is a little tenderness and swelling. The knee does not feel unstable or give out during activity. No increased laxity and there is a firm end feel. Grade 2 sprain. The fibers of the ligament are partially torn or incomplete tear with hemorrhage. There is a little tenderness and moderate swelling with some loss of function. The joint may feel unstable or give out during activity. Increased anterior translation. Yet there is still a firm end point. Painful and pain increase with Lachman's anterior drawer stress tests. The fibers of the ligament are completely torn, ruptured. The ligament itself is torn completely into 2 parts. There is tenderness, but limited pain, especially when compared to the seriousness of the injury. There may be a little swelling, or a lot of swelling. The ligament cannot control knee movements. The knee feels unstable or gives out at certain times. There is also rotational instability, as indicated by a positive pivot shift test. No endpoint is evident. Hemarthrosis occurs within 1 to 2 hours. Clinical presentation occurs after either a cutting maneuver or single leg standing, landing or jumping. There may be an audible pop or crack at the time of injury, a feeling of initial instability, which may be masked later by extensive swelling, episodes of giving way especially on pivoting or twisting motions. Patient has a trick knee and predictable instability. A torn ACL is extremely painful, particularly immediately after sustaining the injury. Swelling of the knee. Usually immediate and extensive, but can be minimal or delayed. Restricted movement, especially an inability to fully extend the knee. Possible widespread mild tenderness. Tenderness at the medial side of the joint, which may indicate cartilage injury. Associated injuries. 1. Meniscal lesions. Over 50% of all ACL ruptures have associated meniscal injuries. If seen in combination with a medial meniscus tear and an MCL injury, it is termed O'Donoghue's triad, which has 3 components. 2. Anterior cruciate ligament, ACL, tear. 3. Medial collateral ligament, MCL, tear. 4. Bone contusions and microfractures. 5. Chondral injury. Six. Tibial plateau fractures. 7. Posterolateral corner injury. 8. Popliteal cyst. 9. Diagnostic procedures. Physical assessment, which includes the following tests. Lockman test. Anterior drawer test of the knee. Pivot shift. One. Radiographs. Radiographs of the knee should be performed when an ACL tear is suspected, including AP, anterior to posterior, view, lateral view, and patellofemoral projection. 2. MRI. MRI has the advantage of providing a clearly defined image of all the anatomic structures of the knee. MRI can diagnose ACL injuries with an accuracy of 95% or better. 3. Instrumented laxity testing. Arthrometric evaluation of the knee. 4. Dynamic ultrasonography. Differential diagnosis. The same characteristics for an ACL injury can be found with 1. Knee dislocations. 2. Meniscal injuries. 3. Collateral ligaments injury. 4. Posterolateral corner injuries to the knee. Other problems that have to be considered are patellar dislocation or fracture, femoral, tibial or fibular fracture. Examination. The examination of ACL injury can be done in 2 ways. 1. Physical or clinical examination. 2. Examination under anesthesia and arthroscopy. Physical or clinical examination. Overall alignment of the knee. Severe distortion of the normal alignment may represent a fracture of the distal femur or proximal tibia or indicate knee dislocation. Any gross effusion, which is most commonly present within a few hours after an ACL injury. Bony abnormality may suggest an associated fracture of the tibial plateau. Palpation follows inspection and should begin with the uninvolved extremity. Palpation confirms the presence and degree of effusion and bony injury. Periarticular tenderness should also be examined. Laxity testing should be done either with the special test or with the help of arthrometer. Injury prevention. There are 5 key steps that should be included in the planning of this program. 1. Identification. 2. Exercises. 3. Training load and volume. 4. Training frequency. 5. Exercise timing. Most ACL injuries occur when an anterior force is applied to the tibia. It is important to identify the risk factors that can contribute to this anterior force to reduce the chance of injury. These modifiable risk factors are sorted into 4 different categories, including movement and alignment, strength, ground reaction forces, GRFs, and fatigue. Thanks for watching our videos. Please like, share, and subscribe. And press the bell button for further notification.